Good evening all. First of all, I would like to thank Dr. Hari and Team Yashoda for giving an opportunity here. So this is the last talk of the conference, and thanks a lot for being here. So we're going to do in another 15 minutes time. We're going to be as brief as possible. So greetings from Visakhapatnam. This is a coast city in India. So this is what the agenda would be, starting with a brief introduction. We'll all discuss about the flexible and rigid bronchoscopic instruments and accessories. We'll discuss a few foreign body case examples and very few case examples on airway tumor debulking. So we're going to start with this. Foreign body is a very, very rewarding procedure because usually it happens in children and the children is in respiratory distress. It's a curative procedure and it's not a diagnostic procedure. Majority of the times you can extract the foreign body and the outcomes are very good and can be discharged as early as possible. And this is the most rewarding procedure in pediatrics, especially in interventional pediatrics. To have for. So we have two types of systems, flexible and rigid. So if you want to have the best possible outcome, choose two of the bronchoscopes, 4 mm, 2 mm and 2.8 or 1.2 or a 3 and a 1.7. Either work will fine. So if you have these two bronchoscope in your armamentarium, this is more than sufficient to do most of the cases. So coming to the instruments, we have 4 different types. One is a basket, forceps, balloon and a cryoprobe. If you have the first 3, basket, forceps and balloon, I believe you can do 80% of all your foreign body cases. If you have a cryo, it's much more advantageous. You can also have specialized instruments like grasp it or a tri-prong forceps. I'm not going to add up much in retrieval. So this is how we use all different types of accessories starting from basket, forceps, balloon and a cryoprobe. So these are self-explanatory, we don't have to know further. So coming to the rigid bronchoscopic system. So this is the original system developed by Chevalier Jackson more than 100 years ago. You can see this is a conical tube. This is a conical cylindrical tube. The proximal part is wider and the distal part is narrower. So you need to visualize from the proximal part, then there is no telescopic vision at that point in time. So you'll have a end-on view, very narrow view. So if you think this is the challenging part, and believe me, you have to pass an instrument to hold the foreign body. And this is not so technically easy. So the current system where you can use a telescope to magnify everything and project it over the monitor, and you can use an optical forceps where you can combine the vision and the instrument in one way, is going to be a much advantage. Why I've shown you this slide is, many of the times if I say rigid bronchoscopy in pediatric population, everybody is skeptical, should we do it or not? So if you look at the current system, it is very, very easy. So these are the different types of rigid bronchoscopes available. This is and different adapters. So we're not going to go and discuss about each and every part of it. So this is what we are focused on. In rigid bronchoscopy, the instrument of choice, what we have is an optical forceps. I have told you we can combine the vision and the instrument. With one single hand, you can retrieve the foreign body. So these I call the simple distal foreign bodies, where there is no much of granulation, no big obstruction, no big problem you have to manage. Either you can use a rigid system or a flexible system. Rigid with an optical forceps, flexible with a basket or a forceps, you can retrieve the foreign body. So this doesn't cause major problems. So if you have a challenging case, like this case of a distal airway foreign body, when there is no space around. So if you don't have any space around, all your instruments like basket, balloon are going to fail. So in this case, the basket has failed. So what we had to use a cryoprobe to disimpact the foreign body. So once you disimpact the foreign body and get it proximal, it is very, very easy to retrieve again with a basket or a forceps. So in this case, cryo was a major advantages where I could able to disimpact the foreign body proximally and extract it. Obviously it has gone to the other side, but it is not a problem. We used a basket to extract it. So what if you have a foreign body with a proximal granulation? This is a 4-year-old child, chest X-ray, some consolidation. In the CT also you can see the consolidation there. So what was happening was, so when you do a bronchoscopy, you can see a polypoidal lesion just proximal to the foreign body. So used a snare to address the granulation first. So address the granulation. Once you address the granulation, if you remove the granulation, then you are able to see the foreign body deep inside. I'll agree there is some part of granulation which is left out. The challenge is to, once you remove the foreign body, believe me, you don't have to think about the granulation disappears. Here I used a balloon initially to proximally dislodge it, but balloon failed, so I had to use a basket to retrieve it. So the idea I want to convey here is, so sometimes you will see foreign body with proximal granulation, and you need to address the granulation first, either with a hot therapy or a cold therapy. Either one should be fine. Yeah. So this is not my case, this is Hari's case. What if you have a distally impacted foreign body where visually you can't see with a bronchoscope? So there you can use a C-arm for your help to retrieve the sharp object with a forceps under the C-arm. So this is a challenging case. A 10-month-old baby presented with a foreign body of a LED bulb. So in the right side, I thought initially it is in the right main bronchus, but it is far deep inside. It is in the right lower lobe bronchus. So the CT shows the same thing. So initially did a rigid bronchoscopy. So we saw some secretions there. So once you clear the secretions, what you can see, so that's the lower lobe bronchus. You can see the middle lobe bronchus there. The foreign body is deeply impacted in the right lower lobe bronchus. So initially tried with an optical forceps, not able to reach the right lower lobe bronchus with an optical forceps, had to rethink to do what next? Change to a flexible bronchoscope through the rigid bronchoscope. So used a 1 mm biopsy forceps. So once you grasp the foreign body with an 1 mm biopsy forceps, and you can safely retrieve it proximally, and then you can extract with either with the same forceps or with an optical forceps. The point I wanted to make here is sometimes your rigid bronchoscopy can fail. So the reason because it is a distally impacted foreign body and it's a 10-month-old child, the optical forceps was too large to open there, whereas a small 1 mm biopsy forceps was enough to open there and to get the foreign body proximally. So this is what I want to convey. So another challenging case, the bilateral airway foreign body, you can see the endotracheal tube there. The right upper lobe is consolidated. The endotracheal tube is mildly towards the right side. So once you see the endotracheal tube going off, and there is a foreign body there in the right intermediate bronchus, another foreign body in the left lower lobe bronchus. So this is a bilateral airway foreign body. Baby is arrested in the ER, intubated, did a CT scan, and this is what the result was. So there was one foreign body in the right intermediate bronchus and another one the left main bronchus. And the only patent bronchus is the right upper lobe, and that also it's consolidated. It was a challenging case for us to do. And the initial diagnostic bronchoscopy shows the same thing. So we had a greater problem in ventilating this child. So while retrieving the right foreign body, I have inadvertently pushed it inside. It was a greater help for me. So once I pushed it inside, I was able to ventilate the child much better. So I was able to retrieve the right main intermediate bronchus foreign body with an optical forceps. And the left main bronchus foreign body, I had to retrieve with a balloon. So just want to highlight the use of both systems. Neither is superior to other. So if one fails, other should be at help. So this is another interesting case. 4-year-old child presented to ER in the middle of the night. So he came whistling, saying that is a subglottic whistle which is got stuck, impacted, and saturation drastically dropped to 80% in 15 liters, and PCO2 was 60, and baby was gasping. So initially tried retrieving with an optical forceps, not able to retrieve. So because it's at the subglottis, so I had to push it down, catch hold it again and try to retrieve. During this time, so when I was able to retrieve it, one of the jaw of the optical forceps has broken. So now I have created another foreign body inside the airway. So the other foreign, luckily I had a spare optical forceps at that point in time. First I was able to retrieve the foreign body, what I have done. So after that, what can we do? So we can do a tracheostomy to extract the foreign body, or you can do something else to extract the foreign body. That was serial dilatation of subglottis with increasing size of rigid bronchoscope. The problem is at the subglottis, it's not able to coming out because of the edema, and also of this, because of the edema is not able to come out. So we gently dilated the subglottis with increasing serial sizes of bronchoscope. We were able to retrieve the foreign body. So the idea I was telling you is, so if you have a tight subglottis, in certain cases you can gently dilate it and use the best forceps available to retrieve it. Another case, foreign body present with an obstructive hyperinflation and pneumothorax with subcutaneous emphysema. So you can see there, that's the carina, and that's the right main bronchus, there is a foreign body, and the right lower lobe bronchus is patent. So that's a foreign body in the right side. Basically, why this happens, this subcutaneous emphysema, initially you have a ball wall mechanism on the right side, you'll start developing pneumothorax, then it ruptures, and you'll have a subcutaneous emphysema. Luckily for this child, all the parts of the con are on the right side, so we're able to retrieve it, and believe me, the subcutaneous emphysema disappears. So this is another challenging case. This is a 2-year-old boy, again presented with similar condition. So we did a CT scan, it shows that there is something in the right main bronchus, and the right lower lobe bronchus is patent. Young boy, sudden onset of breathlessness, cough, diminished breath sounds on one side. Chest X-ray was showing an obstructive hyperinflation and some subcutaneous emphysema. Initially, we thought it was a foreign body. We did a diagnostic bronchoscopy. To our surprise, there was a large mass sitting in the right main bronchus. This is a 2-year-old child, and he was crashing. So we had to do something else. So that initially, what we did was we did probe cautery on the mass and extracted piecemeal. We did a debulking, piecemeal debulking, and we got a good airway patency, and it turned out to be a PNET tumor. And this is the X-ray day 2 post-op, good expansion of the lung. And still the baby is still good. Post-chemotherapy is still doing fine, is still in follow-up. So this is another case. A 7-year-old girl, again presented with collapse on one side. So if you can see the flexible bronchoscope, you can see a large mass sitting on the right main bronchus. So this girl rapidly deteriorated, requiring more oxygen and ventilation. So we had to do a debulking. So initially we talked to the family of placing a child on ECMO if the things go wrong. So but luckily we were able to retrieve it. And so this was in September 2019. In December 2019, when we did a repeat bronchoscopy, it was showing there was a few bumps on the mucosa, but nothing much. So this is after 4 years. In June 2023, and the mass regrew. And this time we didn't want to do any more. So we did a sleeve resection. To my good friend, Dr. Mohan, has helped me in this. So still the baby is in follow-up. He did a sleeve resection and anastomosed the distal bronchus to the carina. And still the baby is doing fine. This is the last case I'm going to show you. An 8-year-old boy with a large tracheal mass presented with stridor and respiratory failure. As you can see in the diagnostic bronchoscopy, you can see a large mass moving in and out of trachea during respiration. That's the reason the baby has a significant stridor. You can see the amount of obstruction in the airway. So because it is a polypoidal mass, used a snare to extract it, and this didn't had major bleeding. We were ready with backup, and we were able to extract the mass. It turned out to be a benign leoma. To summarize, I feel each case of foreign body aspiration is unique. You should follow principle for safe removal. Rigid bronchoscopy is a time-tested system. I don't think physicians should be worried about whether should you do it or not. So for impending respiratory failure, rigid has a better control of ventilation than compared to a flexible. So if with rigid, you can be used as a conduit to perform a flexible bronchoscope. And for rigid, for sharp foreign bodies, rigid is the best system. And for distal airway foreign bodies, rigid has a drawback and flexible is superior. And I believe there is no single best instrument for all the foreign body cases. Rigid or flexible, both are on par with each other. Either one can fail. Thanks for your patient listening.